All right, so it's official. We are starting our sleep apnea, like a mini seminar. It's actually going to be a series of lectures starting today with Dr. Muhammad Abdul Wahab. I just got a question on the group that how often an orthodontist would see a sleep apnea patient. Actually, very, very rare that the patient comes directly to the dentist or to the orthodontist. Usually they go to a sleep medicine clinic and they get to be diagnosed that they have a sleep apnea, and then they come to us. I honestly think this should change in the future. And again, maybe Dr. Abdul Wahab would go over like a simple questionnaire that you can get to ask the patient questions and get to know if he has any symptoms or signs of a sleep apnea, and you get to introduce them that dentists can help you in that regard as well. It reminds me by just a quick story. A patient was doing his Invisalign, and in the middle of the treatment, he's asking me, do you know a good orthodontist who can do braces for my kid? So sometimes the patient doesn't know that we can help them in other things other than, you know, Invisalign or braces. And again, I've seen some cases with really drastic change in the life before and after doing the orthodontic surgery for the sleep apnea cases. So again, I'll leave the podium for Dr. Muhammad. It's going to be a 45-minute lecture, and we're going to leave about 10 minutes for question and answer. So please leave the question to the end so we can have more focus on the lecture. And we're going to try to do that lecture with more depth in the future if Dr. Muhammad's time permits, inshallah. Thank you. Go ahead.
Thank you so much, Dr. Hisham. All right, good morning, everyone. Assalamu alaikum. Today, I'm going to be talking about sleep surgery and moving from history to innovation. I have nothing to disclose other than being part of this amazing team, our division chief, Dr. Capasso, program director, Dr. Sally Liu, and our godfather, Dr. Robert Riley, who actually created the concept of maxillomandibular advancement and skeletal surgery generally in the sleep surgery world and in Stanford. This is my dear friend, Dr. Amr, being part of Stanford as well. So I will try to, go from the history of sleep apnea. And in 1836, actually, after sketches by Boz, which came actually very popular, and then Boz was so excited to, come up with his first book, Pickwick Club, and Boz was actually Charles Dickens, and from his story or his book, they found this interesting character, Joe. Joe was that fat boy who eats a lot and just keeps sleeping and stays sleepy all day long. And then when he sleeps, he snores like a pig. This resulted in the concept of the word Pickwickian syndrome in Western medicine. And this was the seed for development or like thinking of the disease of obstructive sleep apnea. On the other side, Henrik from France actually talked about his story in the early 1800s as well. And we can see this beautiful daughter of Unda, who was the god of water or the sea at that time. And her name was Undine. Undine actually wanted to live a life like a human, since she didn't have a soul and they were immortal. So she came out to, from underground and fell in love with a prince. The prince was, good-looking guy, all that stuff. But then they fell in love and they got married. After their marriage, unfortunately, he cheated on her, and that made her spill a curse on him called the Undine's curse. This was basically making him not breathe if he falls asleep. And this is the origin of the concept of central sleep apnea and how it came to Western medicine as well. And this today, when you hear the word Undine's curse, it actually refers to a certain syndrome, central alveolar hypoventilation syndrome. When you look at both, there are different risk factors for each. I just want to highlight that obstructive sleep apnea has a lot of causes as well as central sleep apnea. So OSA or obstructive sleep apnea starts by nasal obstruction, other causes like enlarged adenoids, tonsils, floppy epiglottis, obesity. And as you've mentioned, there's a lot of causes. And I want to highlight also the abnormal jaw location or position. The patient can be a class 2 or class 3. The tongue size, and we'll go over these as well, but not to forget or overlook the reasons for central sleep apnea, which varies, from brain tumors to diseases like Alzheimer's, Parkinson's. And in the US, we have here a big problem, which is opiate medications. And we're actually we are having a paper about opiate medications among patients with sleep apnea and how it deleteriously affects people's health here in the US. On an individual variation, obstructive sleep apnea have different, impacts. Okay, of course, from daytime to nighttime symptoms. This starts by tiredness, morning headaches, of course, dry mouth, up to traffic and work accidents, irritability, poor concentration, depressions, and other also personality changes and psychiatric disorders. On the nighttime, of course, excessive snoring is one of the deal breakers to a lot of relationships, actually. Gasping for air, restless sleep, nocturia, which is common in children, and it's a very important symptom to highlight for all stakeholders of sleep apnea treatment. And this goes along, as we see, with all these other symptoms. Now, I'm gonna move a little bit forward in history and talk about the history of sleep apnea as a medical term. So this starts as a tale of two cities. Instead, of course, it was also written by Charles Dickens, but this time, instead between Paris and London, it was between Paris and Stanford. This is when Christian Guilleminault came as a visiting professor from University of Paris to meet and work with Belle Dement, who was very interested in sleep physiology, and was actually using, as you can see in this picture, medical students from Stanford to understand more about sleep physiology. They worked together to come up with the first concept of sleep apnea syndrome in 1974 with the way we understand it today, based on the apnea-hypopnea index, which I'm going to be talking about. A year later, they were also able to diagnose this in children in 75, and all this also happened, as you can see, at Stanford. This is Belle Dement, actually, before he passed away 2 years ago. And it's an amazing person, and he actually built the concept of sleep and dream, which is now a very big course for medical students and bioengineers as well at Stanford. Now, this goes on with in history, and here I quote Nelson Powell, who unfortunately passed 5 days ago. Dr. Guilleminault and Dr. Dement were interested in Bob Riley and I, since we both were ENT doctors with maxillofacial training. They were convinced, and that was the necessity for sleep apnea treatment, that sleep apnea patients needed a more aggressive approach than weight loss or tracheotomy.
Recording in progress.
So we can see here, this is a sleep study. If you don't mind muting your phone or your so this is a sleep study from the 70s, and you can see terrible sleep apnea on the PSG. And then this patient underwent a procedure that resulted in total cure of her sleep apnea. But this lady, unfortunately, suffered severe depression. I believe you can guess what procedure she got. She got a tracheostomy, and unfortunately passed away because of her severe depression. So the collaborative work of our mentors here at Stanford has resulted in the development of the original sleep surgery algorithm. And you can see, of course, they focused only on surgery, but again, pre-surgical evaluation involved physical exam, cephalometric analysis, and fiber optic pharyngoscopy. The patient was to pass through phase 1 based on the site of obstruction. So if it was an oropharyngeal obstruction, patient was offered UPPP or uvulopalatopharyngoplasty. Basically, it involves removing the tonsils and doing certain flaps to open up the airway. Unfortunately, at that time, it was all resection. So they resected the soft palate and the pharyngeal muscles. Type 3, or the hypopharyngeal, which is a more lower level at the level of the tongue base and the epiglottis. Those patients were offered genioglossus advancement and hyoid myotomy, which is basically cutting a piece of your chin and pushing it forward to try to push the muscles of the tongue forward through the attachment of the tongue base with the genioglossus muscle towards the genial tubercle. And then type 2 was a combination of both, and those who failed treatment actually were offered phase 2, which is maxillomandibular advancement, or osteotomies as they called it at that time. Back in the 90s, they published their first series, and they noted their success rate to be over 95%. So sleep apnea today actually is a big problem, affecting almost 1 billion over 30 years and over 1 billion if you consider all age groups. If you look at the prevalence of sleep apnea based on the original definition, which is an apnea-hypopnea index of 5 events per hour, the prevalence will go from 9% to almost 83% in a study that came out from Sweden. And this is a very scary number. Again, doesn't mean that we have to follow this definition, but it shows that those patients are really at risk and require careful attention. However, in another study looking at the clinically significant sleep apnea, meaning an AHI of over 15, up to 17% have sleep apnea. Again, a big number. However, this year, Dr. Cabasso and I published this paper, and we looked at patients with insurance, and we found that the prevalence is only 4.34%. This means that, and is supported by the literature from the past, showing that over 80% with at least moderate sleep apnea remain undiagnosed. The diagnosis of sleep apnea starts by sleep studies. Back in the days that as we've seen with Dr. Dement, it was like a hustle to get all these wires. These wires have became, and machines have became more smaller in size. And there are also different types. So we have type 1, 2, 3, 4. I will highlight only 2 types, which is type 1 and 3, because these are the ones we use commonly. Type 1 is the basic polysomnography study. This means that you require at least 7 signals to monitor your sleep. This involves an EEG and EOG, which is, it measures your eye movement, the chin EMG to detect REM sleep. And then we have the ECG, airflow, respiratory effort, and oxygen saturation. Type 2 is basically an unattended one versus type 1, which is an attended one, meaning that there's a technician watching over you. Type 3 is basically what we have now, and I believe the whole biodesign industry and all the biomedical engineering is moving towards more simple ways to monitor your sleep. I believe Dr. Amr, I've talked to you about also an oximeter that came out now FDA approved to do that. For type 3, you have to have at least 4 signals, which is a heart rate monitor, oxygen saturation, respiratory movement, and flow. Sleep apnea diagnosis, as we mentioned, the word AHI, or apnea-hypopnea index. Basically, an apnea, I just want to make sure everyone understands this. So it's it starts by a reduction of over 90% of the airflow to more than 10 seconds. This is basically what an apnea is. A hypopnea, on the other hand, is the same, but instead of more than 90% reduction airflow, no, it's more than 30% reduction airflow. And that's why it's called a hypopnea. However, in the definition, we have also a desaturation or an EEG arousal that is involved in the definition. And finally, we have the RERAs, or the respiratory effort-related arousals, which is, an even more sensitive way to define a hypopnea. And again, the American Academy of Sleep Medicine has been using hypopneas with different terms, as we can see here. And that's why sometimes you get confused, because the definition of hypopnea can be a 50% reduction, sometimes a 30% reduction, sometimes with or without, sometimes with and with a 3% desaturation and EEG arousals. So again, that's the problem. However, to solve this now, we're only using the guidelines of the American Academy of Sleep Medicine on 2012, which shows the final definition of 30% reduction with a 3% desaturation or an EEG arousal. Excuse me. So why do we treat sleep apnea? Simply, the problem with sleep apnea is that nocturnal hypoxemia, the hypoxemia that happens at night. The problem is that it results in different endocrinal and metabolic alterations to our bodies and has been linked strongly with a lot of comorbidities, including endocrinal problems like diabetes, hypertension, cardiovascular problems like and neurovascular like strokes and different forms of arrhythmias. These comorbidities have also been linked to motor vehicle accidents as well as workplace accidents. And last but not least, reduced productivity, resulting in the US, they were able to calculate a problem of $150 billion loss every year because of sleep apnea. On the other hand, treatment involves proper diagnosis, non-surgical and surgical treatment that only costs an annual cost of $12 billion. Now, the question comes in, how do we treat sleep apnea? Again, I want to highlight it's not only surgery. There are non-surgical options. In fact, CPAP is the first line of treatment in a lot of countries, including the US. There's also positional therapy. There's tongue retaining devices, oral appliances, weight loss, different nasal appliances as well. And I want to show you here, there are different modes of CPAP, and this is the impact of CPAP on airway using an endoscope. So you can see how it pneumatically splints as we rise with pressure, pushes the airway and opens up the muscles and splints the airway and avoid it from collapse. Now, CPAP is great. It improves quality of life, performance, cardiovascular disorders. Perfect. The use of over 1 hour per night actually showed to lower the 5-year mortality rates in the population. However, there are a couple of problems with CPAP. First of all, is that adherence is pretty low, ranges from 17 to 54%. And the problem is, imagine you're wearing that mask all night. I mean, your partner may complain, if not from, having this thing on your face, could be from the sound of the machine. Or, I mean, it is a hustle for the patient himself to use this thing all night long. The other problem is that nocturnal hypoxemia does not determine CPAP adherence, meaning that a patient with severe sleep apnea. Do you mind muting? Thank you. Nocturnal hypoxemia does not determine the CPAP adherence, meaning, again, a patient with severe sleep apnea does not necessarily use a CPAP. Another big problem is that failed CPAP on a nightly basis, meaning if the patient doesn't use it for only one night, this may permit re-emergence of his or her sleepiness, neurobehavioral deficits, and even personality changes by time. Now, the question becomes, okay, to answer this question, Picarolo is actually one of the big names and the editor of JAMA Otolaryngology, looked at the different definitions of success for treatment for sleep apnea, and you can find the numbers all over the place, right? Eventually, there was one that was most cited, which was Scher's criteria, and it's basically having a reduction in the AHI below 50% of the pre-op, or having an AHI below 20 after surgery. However, a lot of sleep surgeons and sleep physicians were a little bit concerned about the definition of surgical success and the use of just an AHI, which is solely a number to define surgical success and define sleep apnea. And they report that this oversimplifies the complexity of sleep apnea on the individual and the social level. And this is why a lot of patient-reported outcome measures, and as Dr. Amber has mentioned, these questionnaires, and hopefully I would like to highlight a new questionnaire that we're developing these days. We are collaborating with people from England, Finland, Brazil, Egypt, for building a new questionnaire that has been tested, and results came back from Finland actually 2 days ago, showing a very high rate of accuracy in that questionnaire. The questionnaire will be coming out from Stanford, and hopefully we will be talking to you guys to try to do the Arabic validation, inshallah, soon. Now, to take this a step further, our group here at Stanford with Dr. Capasso and Badr Ibrahim, our former fellow, they looked at clinically relevant outcomes. This means that we're looking at cardiovascular, neurological, and endocrine events. And in this study, we looked at over 50,000 patients and compared patients who had surgery versus patients who had CPAP use. And on both the unadjusted and the PSM matched group, we found that patients who had surgery had significantly less cardiovascular, neurological, and endocrine events. And we attributed this to CPAP adherence. Now, to take this a step further, Dr. Capasso and I looked at the healthcare utilization in those groups. So basically what we did, we looked at patients who had surgery, patients who had CPAP, and patients who had no treatment at all. And you can see the blue line, although surgery is more expensive to start with, over time, it becomes less costly on the healthcare system. So again, this highlights that patients by proxy spend less money and therefore have better health if they undergo surgery compared to no treatment and compared to using medical or CPAP therapy. Now, I want to look at the evolution of surgical procedures by time, and you can see the evolution of soft tissue surgery by time. And you can see here the movement from from aggressive resections, as we can see here, where the soft palate is totally resected, to what we call more preservative and conservative surgeries as preservation pelvic. I think it's my alarm. 1 second. Apologies about that. And then from the skeletal surgeries standpoint, we've realized a movement from aggressive linear movements of the maxillofacial skeleton towards more precise movements, as well as movements with aesthetic considerations and nasal modifications, as we will highlight in the future. So my question to you is, why do we keep adding to our toolkit? Simply, if all you had in your toolkit was a hammer, then every sleep apnea patient is a nail. And that's not the case, owing to the multifactorial etiology of sleep apnea. This can vary between conductive factors or neural factors. Conductive range could range from tonsils to adenoids, sometimes to polyps, but the problem is this is only 2%. And that's why if you're talking to an ENT surgeon, again, if they only focus on soft tissue surgery, that's very, very limited. Second thing is muscle orientation and foundation. Then we have the facial skeletal deficiency, where the maxilla and or the mandible are hypoplastic, or perhaps a combination of all of the above. And also we have over 90% of sleep apnea patients tend to have a multi-level obstruction, meaning the level of obstruction varies not only at the nose, could be in the palate, could be the oropharynx, could be the upper jaw, could be the dental arch, could be the mandible, could be the epiglottis. So again, there's a lot of levels that we can talk about. And last but not least is the phenotypic variations we have, and this involves physiological and anatomical. I'm gonna try to simplify this as much as I can. So physiological phenotypes, there are, in the literature, there are a lot, but these are the most commonly cited phenotypes from a physiological standpoint. So loop gain is the hyper-responsiveness of your ventilatory drive to nocturnal hypoxemia, meaning that when your oxygen levels go down, what happens to you? So what happens is you want to gasp for air, like that. So this response is very high in sleep apnea patients compared to normal people. Then we have the arousal threshold, meaning what is the threshold that you will wake up during night? Again, this is pretty low in sleep apnea patients and explains why those patients have restless sleep. Pharyngeal collapse or the piquete, this is simply at the transmural pressure. And again, it shows that it improves with different forms of therapy, either medical or surgical, oral appliance, surgeries, or CPAP. And then we have our airway muscle response to negative pressure. So in those patients of sleep apnea, they have low response, meaning their muscles are so floppy. So that's why they don't respond well to negative pressure. And this explains their sleep apnea events. Now, from an anatomical standpoint, I've already talked about the Fujita staging system that was used in the original Stanford algorithm, but I want to highlight that we also have the Friedman staging system, and it's based on the tongue position, the Malampati staging, and it's based on the tonsil size. Again, this has been used again extensively in the literature as well. And then recently we had this drug-induced sleep endoscopy, or the DICE. I believe if you work with an ENT back in Egypt, you will find a lot of people talking about this as well, the word DICE. Basically, it's a sleep endoscopy, and I want to show quickly here in this animation. So you look at, first of all, you pass through the nose, but the VOT actually stands for V, which is the velum, which is this area. You want to look at the soft palate. And how it collapses at the level of the nasopharynx. And then you have the oropharynx looking at the lateral pharyngeal wall specifically, and then you have the tongue and its impact on airway as well. And then we have the larynx or the epiglottis. And I want to show you a video of what a DICE looks like. Again, you can see this is the lateral pharyngeal wall. I skipped the velum now, and we're looking at the tongue base back here, and the epiglottis here is actually collapsing. This is a rare example, but that's why I kept it here. Now, sleep surgery today can be defined or divided, if you will, into multiple ways, one of which is intropharyngeal and extrapharyngeal surgery. So when you look at the intropharyngeal surgery, it means that you're working directly on the airway. So this entails pharyngeal wall surgery, palate surgery, tongue-based surgery. Extrapharyngeal involves the skeletal surgery, MMA, or advancement or expansion, whatever type of surgery you prefer. We have the genioglossus advancement, the hyoid surgery, and also the new FDA-approved hypoglossal nerve stimulator. And I believe there are trials to have this technology in Egypt as well. However, I want to highlight that the rise of a patient-centered approach has made us understand more about the phenotypes of our patients. Now, the patient-centered approach is well demonstrated in the updated Stanford sleep surgery algorithm, and I want to highlight patient comes here, and these are our mentors and Dr. Lu and Dr. Capasso, who describe the updated version. And you can see, first of all, you start with patient on CPAP or an oral appliance. So again, the plan is to have a non-surgical option first. If the patient's BMI is a little bit high, then we offer bariatric surgery. If the patient is happy with the CPAP or the oral appliance or both, and not able to use them for certain reasons, one of which is the complications that happen with either CPAP adherence or the complications that happen with oral appliance. Now, the complications with oral appliance, usually patients are very happy initially with such a thing. However, the problem is usually the long-term complications of oral appliances. I was just giving a talk to Miami. They were asking so many questions about the oral appliance. Again, it is done by the orthodontist. However, there are some ENT physicians who do that as well as some sleep medicine board-certified physicians. Oral appliances basically hold your mandible forward, so it kind of tries to do what the MMA, the jaw surgery, do. That being said, if you're not careful and if you did not, counsel your patients about these complications, which involves, teeth mobility, shift of the bite towards a class 3, TMJ problems, having dental caries, dry mouth in the morning, all these issues do have an impact on our patients. And unfortunately, there's a subpopulation of those who we do jaw surgery for are those who had oral appliance for years and had these complications, and now we have to fix things surgically. Without further ado, I want to introduce this algorithm to you. So with this new introduction of drug-induced sleep endoscopy are able to identify the levels of collapse. And want to highlight the introduction of upper airway stimulation surgery has made a huge and tremendous impact on our way of thinking of tongue-based collapse. Of course, we have the tongue-based reduction and robotic surgery, the introduction of the new concepts in palatopharyngoplasty, and finally adding maxillary expansion as a nasal procedure, which is going to be our focus. And last but not least, the changes and the updates of our contemporary MMA, and how it has a lot of new updates on the facial skeletal and the airway as well. I will be starting with talking about the nasal procedures. So this is a study that I believe I did 2 years ago and looked at the different cross-sections of the nose. And we evaluated the different cross-sections. And I'd like to ask the audience, just tell me, which one do you think is the narrowest area in the airway? Is it A, B, or C? Just give me a guess. Perfect. It is C, as you've mentioned. So this region is known as the internal nasal valve. The internal nasal valve has the lowest radius and therefore has the highest resistance. And according to Bernoulli's phenomena, it has the highest likelihood to collapse, with reported airflow of over 30 liters per minute to result in total collapse of this region. Radiologically, we have heavily published on this and validated a new tool using cone beam CT scans to measure the internal nasal valve angle and cross-sectional area. Now, this is Dr. Mose, who I worked with as a facial plastic surgeon first, before becoming a sleep surgeon. And we have extensively published on different ways to open the internal nasal valve. There are spreader grafts, all these different ways of fixing the nasal valve. First of all is the lateral crural strut graft. As you can see, this is the nose. And we place a graft to open up and stabilize the nasal valve to avoid it from collapsing. And this is one of my cases. Then we published also another version of it, the miniature or the mini LCSG, simply a smaller piece to open the internal nasal valve without the external nasal valve. Then we have the lateral crural turn-in flap, which is basically using the own cartilage to open up and support the lateral cruce. And then we have the lateral crural overlay as well, with or without support. And this is also the Alar spanning suture. It's like away. Sorry about the voice. So you can see the impact of these sutures to try to support the beginning of your airway. Anterior septal reconstruction grafts. Again, this. So this groove is going to go through the nasal spine, and it's just really. Sorry about the sound. Again, different forms of ways to open the nasal valve, and again, spreader grafts, which kind of opens up the apex of the nasal valve. We published again extensively on that. So if you look at all these options, these are all great tools to open up the nasal valve. But my question to you is, what if all this fails to work? Why did it not work, and what should you do? Now, to answer this question, I'm going to go back 3,000 years ago and ask you simply, what are the differences between the three pyramids of Giza or what is the most contributing factor to the differences in volume between the three pyramids of Giza? Well, Egyptologists looked at this very carefully, and they found it was not the angle of the apex, it was not the slope of the pyramid, it was not the height of the pyramid. However, it was the base of the surface area. Oh, sorry, the surface area of the base. The pyramid is not that different from the upper airway complex or the nasomaxillary complex. In this paper by our former fellows, they looked at patients who failed nasal surgery, especially for the nasal valve, and they realized that those patients seem to have something in common. First of all, they realized that their nasal floor in the anterior nasal cavity and the middle nasal cavity were smaller, or let's say narrower, in those patients. And then they looked at the palatal morphology, and also interestingly, they found that those patients tend to have a narrower palate and a more high-arched vault, if you will. And this leads us to talk about the high-arched narrow palate, which is simply a maxillofacial deformity that's characterized by a transverse maxillary deficiency when you compare it to the mandible. And I want to show here an example of a pediatric and an adult image. And rhinomanometry studies actually looked at the internal nasal valve resistance in those patients, and they found that those patients have higher resistance and higher likelihood of nasal valve collapse when compared to normal people with normal palatal vaults. More than that, also this study showed that patients with high arch narrow palate, as you can see, result in collapse of the tongue base more posteriorly, resulting in airway obstruction during sleep. Again, because the volume in the oral cavity is smaller, then there's no room for the tongue to stay up there. And therefore, it either, you either have your tongue base fall back, obstruct your airway, or end up with an open mouth, which actually increases the resistance of your airway. This has also been linked very strongly with pediatric nasal obstruction and pediatric sleep apnea, ever since that study that came by Harvard in 1981, when he got a group of rhesus monkeys, and blocked their noses with silicone implants and realized that their dental arch changed in shape. They ended up with high arch narrow palates. Then he removed these silicone implants and looked at those monkeys, and finally they changed to normal again. So this gives me a chance to talk about pediatric sleep apnea real quick. So again, we are more sensitive for children, or let's say for teenagers even below 18, where we identify sleep apnea, and instead of HI above 5, it's HI above 2. I also want to highlight that as an orthodontist, you need to have a really a low threshold in identifying your patients, especially if they mention something like excessive daytime sleepiness. The parents say, oh, my kid has academic difficulties or a hyperactive behavior, and ADHD actually has been linked to sleep apnea as well. Hypertension in a younger age in teenagers or children. In uresis, if the mom comes, oh, there's bedwetting after the age of 2 or 3, you have to raise the awareness about the possibility of a sleep apnea in this patient. And again, of course, obesity has been always linked with sleep apnea as well. This paper actually showed a lot of risk factors for sleep apnea, but it caught my attention to look at some of these factors actually share a very common thing. Those reasons here are all resulting in nasal breathing issues, right? And even in the craniofacial anomalies, when I dissected this carefully, all the syndromes from Down syndrome to achondroplasia to Pierre-Robin, they all share a small or a narrow nasomaxillary complex. To copy what happened in his study by Harvard in the monkeys, this group looked at patients who had unilateral nasal obstruction because their nose was completely blocked due to something called guanal atresia. And they realized that those patients ended up having a smaller nasal floor at one side, indicating that those patients tend to have a smaller palate because of airway obstruction. Now, the concept of maxillary expansion actually started in the 1860s, actually here in San Francisco, not too far from the birth of sleep apnea syndrome. And this is Dr. Engel, who first described the concept of maxillary expansion, actually started the first case on a 14-year-old girl. He used 2 gold rotated rotatory screws. And as we can see, he used it for over the molars and realized expansion of the maxilla. And then in Dental Cosmos, he published his first paper, but he was, totally confronted and actually fought against by a lot of orthodontists and dentists at the time, and they mentioned that his results are exceedingly doubtful. Maxillary expansion has continued to grow with Engel after this confrontation, and he published a lot. And now moving forward to 75, you can realize that it has been one of the very effective ways to manage the high arch narrow palate. In fact, it has shown ever since the 70s to improve nasal respiration and breathing, improve sleep pattern and snoring. And this is one of the things we realize in all our patients we do maxillary expansion for, improve respiratory infections, even asthma and lower respiratory problems, and as well as speech clarity. And this is supporting evidence from the literature that patients who undergo maxillary expansion tend to have even improvement in their voice. So maxillary expansion basically is, placing an expander. And if we're talking about kids, again, this is done totally by the orthodontist. However, our role is usually to guide the parents to what to do. Again, usually the amount of force generated is about 2 to 5 kilograms with indicative of an accumulated load of over 9 kilograms. The way we do it here, usually, especially for kids, 2 turns per day. And the types of maxillary expanders, I'm sure you're all experts in this, but again, there's the removal and fixed appliances. Our orthodontists prefer usually the fixed, and the fixed could be a tooth and tissue borne, like the Hess, as we see here in figure A, or you have the tooth borne as well. And there's finally the micro implants assisted maxillary expansion, or a short term for MARPI. Now, we looked at patients or children who had maxillary expansion, and we measured the nasal valve angle and cross-sectional area and realized there is improvement in both the nasal valve angle and cross-sectional area. You can see here there's a negative correlation between the nose scores and the amount of expansion. So there's an improvement subjectively, but also interestingly and not surprisingly, that the age negatively correlated with the diastema we end up with. And this is supported by the facts we know from facial development, right? So by 6 years, your palatal growth is complete. And by 13 to 15, which is the age of puberty, there's an increase in the interdigitation and fusion of the suture, resulting in difficult separation. So what if we are too late and adolescence ships away? Maxillary expansion in adults is still an option. And there's actually a lot of forms. There's dome, MARPI, SARPI as well, which is surgically assisted. However, in this talk, I'm going to highlight the talk about dome. So dome was first introduced here in the American Academy by Dr. Liu, my program director, and Audrey Yoon, one of the orthodontists we work with. And it's simply placing an expander bound to the teeth first, and then we place the implants, usually by the orthodontist or the surgeon at the time of surgery. This is followed by a Le-Fort 1 osteotomy, as we can see here, and then followed by a mid-sagittal split. They published their results showing subjective and objective improvement. So subjective improvement from a nasal breathing standpoint, and objective from an AHI standpoint. Later on, we looked at the internal nasal valve angle as well in dome, and we find, again, significant improvement in the angle and cross-sectional area, and also significant correlation between nose scores and the degree of improvement we have. A group from Brazil actually looked at the lower pharyngeal volume and the total pharyngeal volume, and they found that by maxillary expansion, the tongue moves forward, and therefore it opens the airway, particularly behind the tongue. This is another study looking at the CFD analysis and the resistance of the airway. It shows reduced resistance and velocity, indicating better breathing from an objective standpoint. Another study we're running looking at different airway, so we're using, but this is for dome, and again, showing significant improvement of the airway as well. This study actually just got accepted 2 weeks ago. We looked at patients who failed those nasal procedures and expanded them and found improvement in their sleepiness scores as well as in their nasal breathing. With UCSF, we're running this study. Again, we're using the first study to use cone beam CT scans to measure adenoids and tonsils. And with our orthodontic colleagues there, we were able to determine two groups, a group which was control and then a group of expansion. And we realized shrinkage in the size of adenoids and tonsils after maxillary expansion. And we attribute this to reduced resistance and irritation to the airway after maxillary expansion in kids. From a technical standpoint, this is our new technique now. So now we do not do the big sublabial approaches. Everything now is done transnasal and endoscopic using our ENT skills and knowledge. You can see here the placement of the screws in a very narrow patient. Of course, this is an adult patient. That's why we have to do the osteotomies. This is a transnasal using the scope going to the anterior wall of the maxilla. Identifying the infraorbital nerve, then making our fourth one cut using an ultrasonic osteotome called a sonopet. And the maxillary sinus drains all this water, so it's not in your face. And you can see here the final look. This is the other side, doing the fourth one osteotomy. And then the mid-sagittal split, it's a small cut in the front, and then using again the guided osteotome, and then using wedging technique osteotomes to open up the diastema. And before we leave the OR, we have to make sure that the expander works well. There's no resistance. The expansion is successful. To add to escalate level of precision, we launched now Dome G or Dome Guided, where we have guided implants to make sure we have symmetric cuts between both sides. And we also, from the cone beam CT scan, we're able to do a heat map to identify where are the highest points of resistance. So we want to make sure that those are cut. Now, this is another, based on my former background as a facial plastic surgeon, this is the SCHNOS, which is a questionnaire that was heavily validated first developed in English. And this is our group here at Stanford. And then I want to highlight that it has been validated in a lot of language. It's been my honor to publish the Arabic version of it. And again, finally, we wanted to make sure that patients, breathe better and look better. So we use this heavily validated tool to evaluate nasal function and cosmesis. And again, as you can see, significant improvement in all the SCHNOS-O scores. Basically, these are the questions responsible for airway. While the SCHNOS-C, which is questions responsible for how your face looks like, especially the nose and the mid-face, we realized no significant changes, although it was moving towards better. We don't know why. Is it because, improved breathing? But there was no, bad impact, no perception of widening, if you will. For this talk, I will stop here and conclude by that early diagnosis and evaluation is key. And I want to highlight the role of orthodontists in seeing those patients even before they see us. Because if they see us, this means that sleep apnea has been there for a while. And so again, orthodontists are really a very important key step, and I would say have the best screening option for those patients. Want to highlight nasal breathing in children should always be asked for, evaluating for patients with high arch palate, cross spines, and overcrowded teeth. Early intervention with rapid maxillary expansion has shown to not only improve nasal breathing, but also the size of the adenoids and tonsils do shrink. You actually may save the parents or the children surgery. Maxillary expansion in adults requires a collaborative work. As you've seen, we do, as surgeons, have to do the cuts. The patient has to continue doing the expansion. This will result, of course, in a diastema. Again, then the orthodontist's job is to put the teeth back without, so again, we achieve bone expansion, but then we ask the orthodontist to move the teeth without affecting the bone by keeping the expander in place. And then maxillary expansion improves both nasal breathing and tongue position. And this is key mechanisms for how maxillary expansion works. Thank you so much for this opportunity. And this is my contact in case you have any questions for me. Next, we'll be talking about other procedures and more about jaw surgery, as well as the role of orthodontists in this. But for today, I'm going to stop here for time.
As expected, really very informative, well-designed lecture. I really appreciate your time and effort to do that. And we can have like another 10 minutes for Q&A. So if anyone has a question, he can go ahead and ask Dr. Muhammad Abdul Wahab from Stanford Hospital.
I know it. I know it. All right. Yeah, great question. What's the difference between SARPI and dome? Thank you for asking this. Dome initially was described to do a Lefort 1 osteotomy mid-sagittal split without a pterygomaxillary separation. However, it's based on what the patient wants. So sometimes the patient has, the main problem is posterior crossbite. In this case, we have to focus on the posterior portion. And that being said, our expansion and our collaboration with our orthodontist will be, we need more posterior expansion, and therefore we will ask, a certain positioning of the expander, as well as we will do the pterygomaxillary separation in this case. Other patients who come mainly for sleep apnea don't have crossbite, but really have a high arch narrow palate. In this case, I want to focus more on the anterior nasal cavity, and therefore I would defer the pterygomaxillary separation. Again, basically, it's not that of a huge difference, but from a surgical standpoint, there is a bunch of things that nuances, if you will, that we try to do.
I guess one of the questions that I maybe sent you on the text is that if we do expand in the upper surgically adult patient, and I guess the lower jaw, we're kind of confined how we're going to be expanding it. So I know you have good experience with orthognathic surgery. Is there any way if we expand the upper arch surgically in adult patient, we can do the same for the mandible or not?
Yeah, great question, of course. And the thing is, usually you end up with some, again, since it's kind of, it's a gradual procedure, we don't do a multi-piece Lefort. So there is some time for the compensation to happen, some tipping and tilting of the teeth that happens. And again, the problem with mandibular expansion, usually it's, a very high rate of recurrence, and in our hands, there was not much of a difference. That's one part. The second part is usually patients who show up for dome are actually candidates for MMA as well. And this is also one of the things that we believe, not only that you open up the airway, you also give them time for pre-op orthodontia as well. So this kind of helps with occlusion eventually.
Good point.
Rate of expansion is the same with dome as conventional expansion. A really nice question. So in what we do here at Stanford, we usually look at the patient from an age standpoint. So let's say I have a patient who just turned 20 or 21. This patient just needs this loosening by the dome, and then the rate of expansion will be pretty much similar to the children or the teenager age group. If you're dealing with a patient who's 40 years old or above, well, you are not dealing with the same healing power. The healing power is so different. And therefore, you have to be a little bit careful because, again, dome has complications. And I should have mentioned that as well. So when you have higher, a fast rate of expansion, not only does the bone may not handle this, but the mucosa itself may not. So you may end up with fistulas because of this so rapid expansion. And this is why after dome or SARPI, whatever procedure you prefer, with your local surgeon, I always recommend that consolidation period where you don't do anything after the procedure, don't do expansion, nothing. Just wait till the patient heals. And then after 10 to sometimes 7 to 14 days, an average of 10 days, we start our expansion. And then we take it slowly, especially in older age groups. The rate of expansion is usually from 0.25 to 0.5 a day for those who are below 40. For above 40, we have two options. You either expand them by 0.125 a day, or by 0.5 every other day.
All right. Any other questions? We'll get a few more minutes. So I guess maybe on a personal level, what's the number of orthodontic surgeries done at Stanford, probably in a weekly basis?
Great question. Again, it always fluctuates, but I would say an average rate of 2 to 3 a week. Again, we do this for all the different purposes, and again, I will highlight this next time. So we do have, people who come mainly for breathing. This is our main goal, and those patients need a different form of, advancement, and that's why we separate the word maxillomandibular advancement from orthognathic surgery, because orthognathic surgery is in fact a bony surgery to fix a bony problem, which is the bite. MMA is a bony surgery that fixes a soft tissue problem. And therefore, you need more bony movements to end up with a really evident effect on your airway. And as I will highlight, the main thing is to provide tension to your airway. It's not only about the volume that you give, but it's also about the tension you provide to these muscles. And that's why it has to be under tension. And again, this is why when we're talking about MMA and surgeon.
Let me mute that. Go ahead. I'm sorry.
The orthognathic surgeons would say, oh, MMA is similar. Absolutely not. The way you fix the mandible in an MMA case or an airway case is totally different. You're not dealing with the same bone marrow, nice bone marrow in the mandible where you split your saw just goes in there. No, you have to be really careful because the marrow is gone. You're hitting solid bone, and the rates of fracture and complications, according to a really nice study that came out from Harvard, showed the complication rates are way higher in those patients. In fact, I believe it was like an 8-fold increase if the patient had sleep apnea. So again, we are very specific in this detail and all the technical aspects of it. And again, of course, monitoring the patients after surgery, as well as the time that we spend and the way we fix the tube and the way we deal with the orthodontist afterwards. It's just, I believe, totally different from the orthognathic cases. That being said, we also do orthognathic cases, of course.
Okay. So again, thanks again for your time. Very, very informative information. I hope all enjoyed it, and inshallah, we'll try to get a second lecture about, the surgery itself, and maybe relapse, patient who get the surgery, would they, come back for a second surgery after years and years of the operation, and just maybe get more on the details of it. Being an orthodontist, I've only been once in the operation for orthodontic surgery, so maybe having more details of that would be really appreciating. Thank you so much, Dr. Muhammad, and inshallah, looking forward to see you again in the future in another Zoom meeting.
Inshallah. Thank you so much, Dr. Amr. I really appreciate the kind invitation, and thank you all for sticking around and hope to see you soon. Have a good day.